Hello and welcome to another episode of our oncology podcast series, Onc Now. This series was designed to spotlight the leading experts in all subspecialties of oncology, and today I'm delighted to be joined by Dr. Heather McArthur, Associate Professor at the Department of Medicine at the University of Texas, UT Southwestern Medical Center. Heather began her academic career with physiology at the University of British Columbia before obtaining her medical degree from the University of Toronto. Following her internal medicine residency, she completed a fellowship in medical oncology at the British Columbia Cancer Agency and then pursued advanced clinical research in breast cancer at Memorial Sloan Kettering Cancer Center in New York, and earning a master's in public health in clinical effectiveness from Harvard University. It's my pleasure to welcome Dr. Heather McArthur to the Onc Now podcast, and I hope you enjoyed the conversation as much as we did.
So, Dr. Heather McArthur, wonderful to have you join us here on the podcast.
Great to be with you today. Thank you.
So, I want to talk about breast cancer, obviously, and breast cancer treatments evolved rapidly, certainly since I graduated from medical school in the dim and distant past, and the rate of acceleration seems to be accelerating, particularly in things like immunotherapy and targeted therapies, concepts that didn't exist back in my day. From your perspective, what have been the most transformative breakthroughs, and maybe talk us through how that's made an impact?
Certainly. So I think you're absolutely right in that it's an incredibly hopeful and optimistic time to be treating breast cancer with an unprecedented number of health authority approvals of novel drugs with benchmarks that are dramatically different than they were a few years ago, improvements in cure rates in the early stage setting and significant improvements in overall survival in the metastatic setting. So they've really been huge leaps and bounds in terms of improvements. And as you pointed out, some of the areas that have been most successful have been in the area of immune therapy for the treatment of certainly triple negative breast cancer, where it's a standard of care for metastatic and early stage disease. But we've more recently seen signals from randomized phase 3 trials that it may be relevant in certain subtypes of estrogen receptor positive early stage breast cancer as well. So the appeal of immune therapy is that if you can train the immune system to better recognize the specific antigens of the tumor, whatever they are, that you can develop a long-term vaccine-like effect. And so it sort of overcomes the issue of heterogeneity or diversity because you're exposing antigens, whatever they might be, and it's sort of tumor agnostic. On the flip side, we've seen tremendous innovation in the way of targeted therapy. So further genomic insights that have allowed us to develop treatments that are specifically designed to take advantage of genomic alterations. And there have been a number of examples in recent years, including elacestrant, for example, which targets the ESR1 or estrogen receptor mutation and has really changed the paradigm for the treatment of ER-positive breast cancer. So two very different strategies, immune, which is sort of tumor agnostic in many ways, and then very tailored or targeted treatment for other subtypes.
So I've got two follow-on questions for you, Heather. The first is, now I lived and worked in the United States for many years, and I love America. I love many things about America, but one has to be so careful about what one communicates to the lay public or in the lay media, because the messaging sometimes gets confused and politicized. So it's a double-part question. How does your side of the profession best educate the general public and the media that speaks to the general public about the advances that are being made, one? And two, as a component of that, how do we do a better job screening women and men for the likelihood of developing a breast cancer?
Well, those are two very different questions. And the Canadian me understands the resource allocation aspect of the first question. So how do we communicate? Well, our conversations with patients, their caregivers, and with media is very much data driven And what I alluded to earlier is really a shift in terms of expectations around novel drugs. So novel drugs can be very expensive, and 3-month improvements in progression-free survival in the metastatic setting, quite frankly, are no longer going to drive clinical practice. We really need to see overall survival advantage. So longer time on planet Earth, and in the curative intent setting, we need to see improved cure rates.
Yeah.
So I think the expectations have really changed for providers, for patients, and that's what we're communicating to the media, is that we're driving decisions based on clinically important improvements and benchmarks. And your second question, which is about screening patients, I mean, there are a number of different aspects to that. There's screening patients for early stage breast cancer. So the American Cancer Society, for example, just reported on 50 years of data. And although the incidence of early stage breast cancer is increasing for most populations, the stage is much lower than it has been historically, in part because of improvements in education and in screening technology. There are some exceptions to that. So we have a lot of work still to do in minority populations. So we're increasingly understanding racial disparities in terms of screening and treatment. And there's more attention being focused on those issues, which is critically important. And then education in the metastatic setting, which is really quite different, which is ensuring that patients, when appropriate, get access to germline genetic testing. So looking for BRCA if they might be a candidate for PARP inhibitor therapy, or tumor genomics if they might be a candidate for any kind of targeted therapy.
Right. Yeah. So I always harken back to the awareness that Angelina Jolie created when she was diagnosed, and take my hat off to her for doing that. It was a very brave thing, especially for someone in Hollywood who trades on that. So you mentioned triple negative breast cancer. It's often considered to be one of the most challenging subtypes to treat, I believe. What are the biggest unmet needs now in managing this condition? And can you summarize the key findings from your recent work on neoadjuvant, it's easy for me to say, neoadjuvant pembrolizumab? I can never pronounce these bloody monoclonal antibody drugs, the adherence to that.
So triple negative breast cancer has historically represented a clinical challenge for a variety of reasons. Number one, the designation triple negative tells you the 3 things that aren't driving the breast cancer. It tells you nothing about what's biologically driving the disease. And so that insight has been lacking in that space. And then these are breast cancers that in the early stage setting are often diagnosed in our younger patients, so our 20 or 30-year-old patients who present with a breast mass that goes undiagnosed because it's thought to be related to peripartum mastitis or some other unrelated condition, and doesn't get worked up in a timely fashion. And then there's a higher incidence in Black and African American populations as well. Often affecting our younger patients. Historically, about a third of patients with early stage triple negative breast cancer have a distant recurrence, and that typically occurs within 2 to 3 years after their early stage diagnosis. And then historically, life expectancy has been 12 to 18 months thereafter. So the fact that it affects young people, that the distant recurrences are so prevalent, that they happen within such a short period of time, and that the life expectancy has been so dismal historically. So the advent of immune therapy in this space was a huge innovation, because historically we were dependent entirely on chemotherapy. And the addition of immune therapy to chemotherapy led to survival improvements in the metastatic space, but moreover, improvements in cure rates in the early stage space, so preventing metastatic disease from occurring. And those improvements in cure rates have improved overall survival with only a handful of years. So there's still a lot of work to be done in that space. The current standard of neoadjuvant chemotherapy with immune therapy, which is a standard of care, requires 4 different cytotoxic agents as partners to achieve those excellent results. So we need Further, better therapies, but also therapies that confer less toxicity. And that's where the antibody drug conjugates have become very exciting and have moved very quickly into this curative intent space for triple negative disease, together with immune therapy.
Right. Just as an aside, I've seen some recent data on conjugates with radioisotopes, actinium-225. Has that been trialed in breast? I've seen it in prostate. Has it been trialed in breast, metastatic breast?
Not to my knowledge, no. I mean, targeted therapies have been a longstanding area of interest for me. So I've looked at immune therapy together with radiation, cryoablation, but they're very difficult types of studies to get funded, quite frankly.
Yeah,
And it's very difficult to find a space for investigator-initiated trials when the pace of industry-sponsored drug development has been so fast and furious in recent
yeah,
years.
yeah, absolutely. Oh, it's just one. I'll do a bit more rootling around on the internet.
Let me know if you find
If I
anything.
find something, yeah,
Yes, please.
the prostate stuff was actually quite interesting and quite encouraging.
I mean,
For
we looked at VTP together
Mm,
with our prostate colleagues when I was at Memorial Sloan Kettering in New
mm,
York, together with immune therapy. So there has been some work done with heat-based sort of local approaches as well.
right.
But I'm not aware of any potential combinations or monotherapy strategies moving
Yeah.
into the mainstream at this time for breast cancer, at least.
Okay. So some of your work has focused on the prevalence and predictive value of genomic alterations, ESR1, so on and so forth, in hormone receptor positive HER2 negative metastatic breast cancer.
Mhm.
With the rise of genomic profiling, how has the understanding of these molecular pathways changed the way that experts like you approach breast cancer treatment?
Oh, these insights have dramatically changed our routine clinical practice. So the prevalence of ESR1 mutations occurs about 40% of the time in patients who are treated with standard of care first line aromatase inhibitor with CDK4/6 inhibitor therapy. So that's our current standard for hormone receptor positive metastatic breast cancer. And these mutations are acquired in response to exposure to the aromatase inhibitors. And so we typically do genomic testing after progression on first line therapy to see if these ESR1 mutations have been identified, because we have a health authority approved oral, very well tolerated drug, elacestrant, for treatment. And so what I think we're able to do now, increasingly what we're able to do, is increase the menu of hormone therapy options for our patients with clinically meaningful impact before we have to consider or go on to conventional systemic cytotoxic chemotherapy. And ESR1 targeted oral therapies is one area where we've been very successful.
Interesting. So, are we moving closer to sort of fully personalized treatment plans? And what are the barriers to that? Cost, of course, and we've both hinted at that and circled around the
Mhm.
issue. What else?
Access. We're definitely moving toward personalized therapies, especially for hormone receptor positive disease, which is, of course, the most prevalent subtype of breast cancer. So that has become, as I said, the hormone therapy with CDK4/6 is a standard of care in the first line setting. So everyone, whenever possible, should, as long as it's clinically appropriate, get access to genomic testing on progression. I think one area where we could improve is in the area of serial testing. So a lot of providers are doing testing up front at diagnosis, then at progression, and then at every progression thereafter. And our uptake of actionable mutations downstream after the second line is very uncommon. So there's probably some opportunity to streamline there. And then, of course, a lot of us are looking toward ctDNA or liquid biopsies to further inform these decisions, both in the curative intent and the metastatic setting. So, can we identify recurrences or progression earlier on and pivot in a way that's clinically meaningful? So, I think that will be forthcoming, but is currently really only um, still being evaluated in clinical trials and isn't really ready for standard of care practice at this time.
Not for prime time. Okay. So you've been a key investigator in some groundbreaking clinical trials, including Keynote 756, Opera. Can you discuss the challenges and opportunities in designing and conducting large-scale international trials, particularly in emerging therapies for breast cancer? I've got some experience running trials, and each time I've done it, I've thought, never again. Never am I going to do this again.
Well, I mean, I was very lucky to be involved in the Keynote 522 experience, which was immune therapy as neoadjuvant partner for chemotherapy for triple negative breast cancer. And we had a lot of signals for both the metastatic and curative intent setting, I-SPY 2, for example, signaling that immune therapy was relevant beyond triple negative breast cancer. And so it was terrific to be part of the Keynote 756 study that showed that the addition of pembrolizumab to neoadjuvant chemotherapy for high-risk ER-positive disease improved pathologic complete response rates by 8.5%. And we don't usually expect improvements in pathologic complete response rates in that subtype of disease. So it was really a terrific response. What we're waiting to see is whether that path CR benefit translates into an event-free survival benefit. So is it an early signal that we're actually improving cure rates with this strategy? But it requires a global effort, as you point out, to run these phase 3 trials, and you want to be globally inclusive because you want diversity of representation. With recent trials that I've been involved with, phase 3 trials on a global scale, there are a number of issues. The war in Russia and the Ukraine, for example, impacted access to drugs for patients who had enrolled and who were participating in trials in those areas. And so there was a huge heavy lift to ensure that patients who needed access to drugs continued to get access to those drugs. So that was a unique challenge. There are parts of the world like China where samples have to be evaluated in the country of origin and can't be exported to external labs, which is what we do in many other parts of the world. And then there's the issue of access and ensuring that sites enroll, serve specific populations. And again, there's a lot of attention now appropriately to ensuring that there's racial and ethnic diversity in our clinical trials, because that has been a huge challenge for us in that the majority of patients who have enrolled historically on clinical trials have been white or Caucasian. And so we want to ensure that there is more diversity so that we have further insight, because there are some biologic differences, it seems, and there are going to be differences in responses, and we do need to have further insights into those issues. So it's appropriate. There's a lot of appropriate attention to those issues right now.
You know, the internet, Heather, is an echo chamber, and if people search for something, the internet, bless it, feeds back the same stuff and reinforces your belief system. And there's a lot of discussion, especially in America at the moment, about diversity. And as scientists, you know, I think we need to stamp our foot on the ground very loudly and say there are biological, as you've said, there are biological differences between people. And if we want to work out what best to do for the human race, we need that instead of the political. It's like conservative or conservative, the little c or the big C. So
Right.
thank you.
Right.
Thank
And
you.
the FDA is mandating it too. So there is more intentional attention to these important issues, which I think is terrific.
Absolutely. So I was perusing your very impressive curriculum vitae, and I noticed a paper from 2023 entitled Changes in Breast Cancer Optoacoustic Imaging Features During Neoadjuvant Therapy and Correlation with Pathologic Response, a Feasibility Study. And it brought to mind a dear departed friend of mine, Richard Davis, who was a surgical oncologist and very clever researcher. And he was evaluating a technology to look at cell membrane electrical potential changes in cancer. And I loved the fact that Richard always thought outside the box. And he would always tell me that if it's obvious, then, it's too late. If you're going to make a profound change, you've got to think of paradigm shifts. Talk to us a little bit about what you did there, and talk to us about thinking outside the box for diagnosis, treatment, and management of these patients that you look after.
Well, I can't take too much credit for that because that was really my radiology colleagues who really spearheaded that effort. But I think that there's tremendous interest in identifying radiologic parameters that we could employ that predict for example, pathologic complete response. Do we really need to take everybody to surgery? Are there some people who could forgo surgery and undergo local therapies? I just spent the weekend at a meeting talking about cryoablation as an alternative to surgery, for example, for very low risk patients with various subtypes of disease. Here, we're doing research not just in optoacoustics, which seems very promising in predicting response, but also in novel injectable biomarkers that are informing my surgical colleagues' decisions around extent of resection. So, predicting clear margins, for example, that they're employing. And then a lot of attention that's being spent on robotic surgery, nipple sparing, more attention to sensation and things that are really important to patients' quality of life. So I think that there are a lot of interesting tailored treatment approaches. I don't want to use the word de-escalation because it's not really a de-escalation. It's trying to tailor the technology appropriately to the clinical scenario. And there's more openness to that now than there has been. These studies, though, are very difficult to fund. So most of them are investigator-initiated trials. And if there isn't a registration pathway for a sponsor, it's hard to get financial support. So we're very much dependent on philanthropy and government sources of support, frankly.
Yeah. Yes, absolutely. But these things are always a collaboration. And I'm just moved to say your use of the word de-escalation. Again, I'm thinking back to when I trained. I'm not ancient, but when I trained, it was not uncommon to see patients in the clinic who'd had a Halstedian radical mastectomy. And thank goodness we're not doing those anymore.
I saw many of those early on in my career,
Yeah.
and they were so disfiguring. It's amazing how far we've come in
Yeah.
terms of refining surgery, radiation, and systemic therapy for our patients.
Yeah, very, very much so. Very much so. Follow-on question for you. Recently, I was privileged and fascinated to speak with a lady named Dr. Azra Raza. She's a professor of medicine and director of the Myelodysplastic Syndrome Center at Columbia. She's a lovely woman, and she also reads poetry online, just a real Renaissance character. And I encourage anyone listening in who hasn't heard that, listen to that. She blew me away. As an oncologist, she wrote a book called The First Cell. And her premise is that we spend so much time, effort, and money treating established cancer that we should focus more on catching the first rather than addressing the last cells. It's obviously a lovely idea. What are your thoughts?
I think it is an elegant idea, and I guess that's where liquid biopsies and ctDNA testing come in, is that if you identify the originator bad player, that you're more likely to be impactful. One of the misconceptions about tumors, certainly in breast cancer, is that it's a homogeneous disease, and it's really a diverse, heterogeneous population of cells. And one thing that we've been focusing on has been targeting all of the elements of both the tumor and the microenvironment for that reason. Because once a tumor is established, what patients don't often understand is that 1 centimeter of tumor is more than 1 million cells, and it's not the same cell over and over again. And so you need different approaches if you're going to attend to all the different cells in the environment. Again, that's why I like immune therapy, because it sort of overcomes some of this issue of heterogeneity. But yes, I think the opportunity is that if you catch a tumor misbehaving earlier on in the form of source cell, that you're more likely to have a targeted or non-targeted therapy that's going to be effective before it becomes a very diverse established population.
I like that expression, misbehaving. It gives it. In fact, I've heard a couple of oncologists use that,
Really?
yes, these are petulant cells and you should treat them with the discipline that you would apply to a petulant teenager.
I was I was thinking of that metaphor as you were saying that, but I have some of those at home, so I won't comment further.
Yeah, thankfully that's in my past, but I'm with you there. So finally, Heather, a question I like to ask every guest who comes on: if there was a magical genie, and I think I know what one of your wishes might be, because you've hinted at it. If you had 3 wishes for your area of healthcare to improve the outcome for the folks you look after, what might they be?
I mean, first and foremost, it would be that we have the breakthrough, and I don't think it'll be one thing, but the 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 push. So we've had so much innovation. We've improved the outcomes for early stage HER2 positive, ER positive, triple negative breast cancer. I would love to be forced into early retirement because we've made people like me completely unnecessary, because we truly have cured disease. And that's lofty, and it won't be a single approach. But that's the ultimate goal, is that medical oncology is rendered no longer useful. In the more immediate term, I think we're seeing a lot of improvement with these novel strategies, whether it be immune therapy, antibody drug conjugate therapy, targeted therapy, where we are seeing huge improvements, clinically important improvements in outcomes for our patients, while at the same time mitigating toxicity. And that's really, I think, the huge immediate opportunity, is to improve outcomes for our patients, while minimizing the really short-term and sometimes long-term debilitating effects of our current strategies. So I think that's the opportunity. And 3, I would say attending to diversity. A one strategy approach to everyone isn't sensible in my mind. We wouldn't do that in any other aspect of our lives. So why would that be applicable for medicine or breast cancer specifically? So I'm really excited about the insights that are going to be forthcoming as we're attending to more diverse populations.
I thought you were going to ask for more money to fund for research.
Well, that's always underscored. But that's not something I have control over. So.
No, it's a wish, Heather. It's a wish. Right?
Okay, money.
You get a 4th wish. You can have more money.
I can't have a do-over.
Yeah, wouldn't it be nice if the people that run the world could actually, and my experience has been that you meet these family offices who are prepared to underwrite or do impact investing in new technologies or underwrite research. It's always the same reason, because they've got a family member that was affected and they've seen it up close and personal. Whereas people like you are seeing it every single day. And if that could become a shared experience, then I think the access to money would somehow improve and we could make even more progress. Sadly, that's all we've got time for. An utter delight talking to you. And I'd like to thank Dr. Heather McArthur for taking the time to speak to us, but also for everything you have done and will doubtless continue to do for people who are living with this diagnosis. Thank you.
Thank you so much for including me. I really appreciate it.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.